ठहरना, क्या नाम है आपका? रिजवान, 1 मिनट और ठहरना अभी है? तो चेयर हो गई है? अच्छा, अस्सलामु अलैकुम व रहमतुल्लाहि व बरकातुहू. The topic for discussion today is phosphate homeostasis, that is inorganic phosphate is intimately involved in cell energy metabolism, intracellular cell energy metabolism, intracellular signaling, and bone mineral homeostasis. Eh? इसमें बोलूं? अच्छा, sorry for interruption. Inorganic phosphate is intimately involved in cell energy metabolism, intracellular signaling, and bone and mineral homeostasis. The normal plasma concentration is 0.8 into 10 to 1.4 millimole. That is 0.48 milligram to 4.34 milligram. The causes of hypophosphatemia are redistribution into cells, refeed after starvation, and respiratory alkalosis, treatment of diabetic ketoacidosis, and inadequate intake of or absorption of phosphates, such as malnutrition and malabsorption, and chronic diarrhea. Phosphate binders and testers, vitamin D deficiency, and resistance, increased renal excretion such as hyperparathyroidism. हाँ, नहीं आ रही? अच्छा, increased, अब ठीक है? Increased renal excretion, hyperparathyroidism, extracellular fluid volume expansion, and with diuresis, and osmotic diuretics, Fenke syndrome, familial hyperphosphatemic rickets, and tumor-induced hypophosphatemia. So, once again, I will enumerate the causes of hypophosphatemia: the refeeding after starvation, poor such as refeeding after redistribution into the cells, such as refeeding after starvation, respiratory alkalosis, and treatment of diabetic ketoacidosis, inadequate intake or absorption, such as malnutrition, malabsorption, chronic diarrhea, phosphate binders and testers, vitamin D deficiency and resistance, hyperparathyroidism, and extracellular fluid volume expansion with diuresis, osmotic diuretics, Fanconi syndromes, familial hypophosphatemic rickets, and tumor-induced hypophosphatemia. Tumor-induced pathophysiology: phosphate may redistribute into the cells during the period of increased energy utilization, such as refeeding after a period of starvation and during systemic alkalosis. However, severe hypophosphatemia usually represents an overall body deficit due to either inadequate intake or absorption through the gut, or excessive renal losses, mostly notably in primary hyperparathyroidism. As the result of acute plasma volume expansion, osmotic diuresis, and diuretics acting on the proximal renal tubule. Less common causes include inherited defects of proximal sodium phosphate co-transporter effect, and tumor-induced osteomalacia due to ectopic production of the hormone fibroblast growth factor 23. Clinical features. The clinical features of phosphate depletion are wide-ranging, reflecting the involvement of phosphate in many aspects of metabolism. Defects appear in the blood, impaired function of the white cells and platelets, and survival of cell lineage is defective. In skeletal muscles, weakness and respiratory failure in respiratory muscles, cardiac muscles weakness results into congestive cardiac failure. Smooth muscles such as will result into ileus, central nervous system decreased consciousness, seizures, and coma, and bone deficiency of phosphate result in osteomalacia in severe prolonged hypophosphatemia. Investigation measurements of creatinine, electrolytes, and phosphate and albumin, calcium, and alkaline. Internet connection अच्छा आ गया. The combination of hypophosphatemia. The investigations are measurement of creatinine, electrolytes, phosphate, albumin, calcium, alkaline phosphatase should be performed. In some cases, measurement of hormone and 25-hydroxyvitamin D may be helpful to exclude osteomalacia or hypophosphatemic rickets. The combination of hypophosphatemia and hypercalcemia suggests primary hyperparathyroidism, which should be further investigated by measurement of parathyroid hormone. The presence of hypocalcemia suggests hypophosphatemic rickets, which should be further investigated with genetic analysis of X-linked hypophosphatemic rickets. Management of hypophosphatemia due to decreased dietary intake or excessive losses involves administration of oral phosphate supplements and high protein, high dairy dietary supplements that are rich in naturally occurring phosphate. Intravenous treatment with sodium and potassium phosphate salts can be used in critical situations, but there is a risk of precipitating hypocalcemia and metastatic calcification. Primary hyperparathyroidism should be treated by parathyroidectomy, and if the patient is not able to undergo surgery, then it should be treated with calcinomimetic such as Sinacalcet, which is a drug. Sinacalcet is a calcimimetic that enhances the sensitivity of calcium sensing receptors, so reducing the PTH level in the blood. So the treatment of hyperparathyroidism is parathyroidectomy. Number 2, there is Sinacalcet, which is a calcimimetic that enhances the sensitivity of calcium sensing receptors, so reducing the PTH level. Then there is the other condition is hyperphosphatemia. The hyperphosphatemia is most commonly caused by acute kidney and chronic kidney injury. Pathophysiology: in acute kidney injury and chronic kidney injury, the primary cause is reduced phosphate excretion as a result of low GFR. In contrast, the hyperphosphatemia in hyperparathyroidism and pseudohypoparathyroidism is due to increased tubular phosphate reabsorption. So, hypoparathyroidism and pseudohypoparathyroidism result into hyperphosphatemia due to increased tubular phosphate reabsorption. Redistribution of phosphate from cells into the plasma can also be a contributing factor in the tumor lysis syndrome and other catabolic states. Phosphate accumulation can be aggravated in any of these conditions if the patient takes phosphate containing patients are inappropriate vitamin D therapy. Clinical features. Clinical features relate to the hypocalcemia, metastatic calcification, hypocalcemia and metastatic calcification in chronic kidney disease with tertiary hyperparathyroidism. Calcium phosphate product occurs. The clinical features of pseudohypoparathyroidism are non-calcium deposits in muscle spasms, secondary hyperparathyroidism, and renal osteodystrophy. Rhabdomyolysis, hyperthermia, fulminant hepatitis, cytotoxic therapy, severe hemolytic anemia, transcellular phosphate shifts, metabolic acidosis, and respiratory acidosis. The blood pH level is greater than 1.46 millimole or 4.5 milligram per deciliter, and the greater than 1.6 millimole or 5 milligram per deciliter. In these cases, hyperphosphatemia, we carry out the management by dietary restriction of phosphate binders, aluminum hydroxide, calcium carbonate, lanthanum, we were, sorry for interruption, we were discussing the management of hyperphosphatemia in patients with kidney diseases should be treated with dietary phosphate restriction, and the use of oral phosphate binders. Hyperphosphatemia, such as oral phosphate binders such as sevelamer, and in hyperphosphatemia in hypoparathyroidism and pseudohypoparathyroidism does not usually require treatment, and hyperphosphatemia associated with tumor lysis syndrome and catabolic states can be treated with intravenous normal saline, which is given to promote phosphate excretion. So once again, we discuss the metabolism of phosphate. The reference level of serum phosphate is generally considered to be 0.8 to 1.5 millimole per liter. Children age less than 1 year, the reference level of phosphate is 1.3 to 2.6 millimole per liter. In children 1 to 16 years, the phosphate level is 0.9 to 1.8 millimole. Significant hypophosphatemia, that is below 0.4 millimole per liter, may occur due to redistribution into cell, renal losses, decreased intake. A normal diet contains plenty of phosphate as it is present in all living organisms. Normally, the dietary intake varies according to the age and other physiological factors such as pregnancy. Etiology: recommended daily intake for children age less than 1 year is 460 milligram. Age greater than 50 years is 700 milligram. Phosphate is absorbed in the intestinal tract. Normally, the majority of this is reabsorbed by the renal tubular cells. Normally, the phosphate is absorbed in the intestinal tract from the diet. Normally, the majority of this is excreted by the kidney and then reabsorbed by renal tubular cells. Vitamin D increases uptake and homeostasis in terms of bone content of phosphate, and renal excretion is controlled by vitamin D, parathyroid hormone, and fibroblast growth factor 23. Etiology is poor intake may be due to poor diet, including eating disorders such as anorexia nervosa, difficulty with chewing and swallowing, and alcohol dependence. Malnutrition due to malabsorption. Severely ill patients is most at risk when they start to recover and move from a catabolic state to an anabolic state. Vitamin D deficiency, gut phosphate binders, for example, aluminum hydroxide, increased renal excretion, which occurs in hyperparathyroidism, increased renal excretion in hyperparathyroidism. Parathyroid hormone reduces reabsorption by the proximal renal tubule. High salt load, reduced sodium and phosphate. Move from extracellular to intracellular cellular compartment. Treatment of diabetic ketoacidosis, refeeding syndrome. High salt, increased renal excretion. The first cause was hyperparathyroidism. Second was vitamin D deficiency, including hypophosphatemic rickets, renal tubular disorders, Fanconi syndromes, renal transplant, drugs causing renal phosphate leak, such as aminoglycosides, cisplatin, tenofovir, heavy metal poisoning, and paraproteinemias by impairing renal tubular function. Osteogenic osteomalacia is a paraneoplastic syndrome of osteomalacia, hypophosphatemia, renal phosphate loss, bone pain, and muscle weakness. It is caused by excessive synthesis and excretion of fibroblast growth factor 23, a phosphaturic hormone that is normally produced by osteocytes. Several Tumors can cause this, but most are benign tumors of mesenchymal origin. Once again, the increased renal excretion is due to hyperparathyroidism. PTH reduces the resorption by the proximal renal tubule. Number two, vitamin D deficiency, including phosphatemic rickets, renal tubular disorders, Fanconi syndromes, renal transplantation, drugs causing renal phosphate leak, aminoglycosides, cisplatin and tenofovir, heavy metal poisoning, and paraproteinemias by impairing renal tubular function. Osteogenic osteomalacia is a paraneoplastic syndrome of osteomalacia, hypophosphatemia, and renal phosphate loss, bone pain, and muscle weakness. It is caused by excessive synthesis and secretion of fibroblast growth factor 23, a phosphaturic hormone that is normally produced by osteocytes. Several tumors can cause this, but most are benign tumors of mesenchymal origin. Move from extracellular to intracellular compartment. Phosphate moves from extracellular to intracellular compartments. Treatment of diabetic ketoacidosis, refeeding syndrome, and acute respiratory alkalosis, the hungry bone syndrome, which occurs after parathyroidectomy, leukemias and lymphomas. Epidemiology. Epidemiology of hypophosphatemia, common in hospitalized patients, 2.2 to 3.1%. Intensive care unit have 45% of patients with hypophosphatemia. In sepsis, 65 to 80% cases are with hypophosphatemia. Chronic alcohol dependency, 30 to 40%. Major trauma, 56 to 75%. COPD, 20%. Hypophosphatemia is more likely in alcohol dependency, diabetic ketoacidosis, burns, and sepsis. X-linked hypophosphatemia, X-linked hypophosphatemic rickets, 1 in 20,000 live births. This condition occurs in adolescents. It is often due to eating disorders. Associated with alcohol, malignancy, and associated with alcohol dependency and malignancy are vitamin D deficiency. Clinical features of hypophosphatemia are chronic and are mild. Hypophosphatemia may be asymptomatic. Phosphate level is usually 0.6 to 0.8 millimole. Fatigue, muscle weakness, diaphragmatic and cardiac and skeletal muscle weakness, bone pain and rhabdomyolysis and altered mental status, confusion and hallucination. Severe acute hypophosphatemia less than 0.3 millimole may present with disorientation, seizures, focal neurological deficits, congestive heart failure, and muscle pain. Severe acute hypophosphatemia less than 0.3 millimole may present with disorientation, seizure, and focal neurological deficits, and congestive heart failure and muscle pain. Syndrome of chronic phosphate loss usually present with bone pain, muscular weakness, skeletal disorders, markedly low phosphate with bone pain and excessive phosphate loss in urine suggest oncogenic osteomalacia. Syndrome of chronic phosphate loss usually present with bone pain, muscular weakness, skeletal disorders, markedly low phosphate with bone pain and excessive phosphate loss in urine suggest oncogenic osteomalacia. Examination, no physical sign. Hypophosphatemic Hypophosphatemia starts in younger age, in childhood. Shows these patients show short stature, bowed legs from rickets. Adults, firm palpation of bones, may show tenderness, hepatomegaly, chronic alcoholism, and underlying malignancy. Investigations for hypophosphatemia are calcium, phosphate, magnesium, plasma protein in the presence of low phosphate. Increased calcium and low phosphate suggest hyperparathyroidism. Decreased calcium suggests low phosphate and high calcium suggests hyperparathyroidism. Low phosphate and low calcium suggest lack of vitamin D, malabsorption, or hungry bone syndrome. Decreased magnesium suggests dietary deficiency. Consider paraproteinemia if globulin is high. Consider paraproteinemia if globulin is high. Renal function and electrolyte. Renal function and electrolytes. Renal tubular disease are causes of electrolyte disturbances. LFTs, raised alkaline phosphatase, and decreased phosphate due to osteomalacia. LFTs, raised alkaline phosphatase, and decreased phosphate due to osteomalacia. PTH and vitamin D levels, parathyroid hormone levels, and vitamin D levels. ABG if respiratory alkalosis, parathyroid hormone, vitamin D level, fasting morning urine phosphate content along with blood sample. Fanconi syndrome demonstrates decreased bicarbonate, decreased urate, urine plasma, urine glucose and amino acid urea, and renal tubular acidosis. X-linked hypophosphatemic genetic testing is carried out. X-rays can help to evaluate osteopenia and osteomalacia. Hyperparathyroidism, looser zones suggest osteomalacia. Erosion of the distal phalanges, clavicles, and circular punch lesions. Bone scintigraph demonstrates increased uptake of multiple areas in severe osteomalacia. Ultrasound of the neck may help to identify enlarged parathyroid glands, but technetium-99m scanning can be more accurate and easier to locate ectopic parathyroid gland. Dual energy X-rays, absorptiometry, bone density scan, chronic phosphate level will cause loss of bone density. Chronic hypophosphatemia will cause loss of bone density. Bone biopsy if X-rays are inconclusive. Management of hypophosphatemia includes, for mild hypophosphatemia, no treatment is required. Severe hypophosphatemia may require artificial ventilation due to the weakness of the respiratory muscles, and it can be a cause of fatality if the acute hypophosphatemia is severe and critical. Treatment is dependent on cause. Treatment of hypophosphatemia is dependent on the cause, severity, and duration. Treat underlying cause. Increase phosphate supplements and oral and parenteral. It can result in severe hypocalcemia and increase phosphate and increase potassium. Patients with poor renal functions have high risk. In celiac disease, Crohn's disease, the underlying disease should be treated, but vitamin D supplements should be given. Oral phosphate supplements may be beneficial in genetic disorders such as X-linked hypophosphatemic rickets. Removal of mesenchymal tumors will eliminate the fibroblast growth factor 23. Vitamin D deficiency. Vitamin D deficiency is treated with oral vitamin D3 or in renal diseases with 125 vitamin D3. Hyperparathyroidectomy should be treated with hyperparathyroidism should be treated with parathyroidectomy. Avoid alcohol, treat eating disorders. To reduce the risk of hypophosphatemia, patient having renal transplant may be considered for parathyroidectomy or calcimimetic agent sinacalcet may be given. Complications of hypophosphatemia. Acute hypophosphatemia can produce seizures, delirium, coma, or focal neurological finding. Acute hypophosphatemia can produce seizure, delirium, coma, and focal neurological finding. There may be heart failure, rhabdomyolysis, acute hemolysis, and leukocyte dysfunction and abnormal LFTs. Heart failure, rhabdomyolysis, and hemolysis can lead to acute kidney injury, platelets dysfunction, glucose intolerance, and metabolic acidosis. Chronic hypophosphatemia due to phosphate loss causes bone pathology, rickets, short stature, and bony deformities in children. Adults may develop osteomalacia with severe bone pain and fractures. Chronic hypophosphatemia due to phosphate loss causes bone pathology, rickets, short stature, and bony deformities in children. Adults may develop osteomalacia with severe bone pain and fractures. Prognosis. Correction of acute hypophosphatemia tends to leave no long-term complication. Failure to recognize and treat an acute severe situation can lead to fatality. X-linked hypophosphatemic rickets and vitamin D resistant rickets are only incompletely treatable and result in lifelong skeletal deformities. 2 to 4-fold increase in mortality in hospitalized patients with severe hypophosphatemia. Prevention. High-risk patients such as renal dialysis, transplant, eating disorders, parathyroidectomy, oral and parenteral supplements should be given. Now, there is other condition is hyperphosphatemia, the increased level of phosphate in blood. The diagnosis is based on blood phosphate level greater than 1.46 millimole per liter or 4.5 per deciliter, or level greater than 4.5 millimole or 14 milligram per deciliter in severe cases. Causes of renal. फिर इंटरनेट गड़बड़ कर रहा है. अच्छा चलो. Causes renal failure. Causes renal failure, pseudohypoparathyroidism, hypoparathyroidism, diabetic ketoacidosis, tumor lysis syndrome means tumor cells are broken down, and rhabdomyolysis means muscles are degraded, which so leads to यार इसको इधर से हटा दो ना. Sorry for interruption, my dear students. Now we are discussing the causes of hyperphosphatemia. जा रही है? हाँ? वो इसमें नजर आता है कि ये चल रहा है कि नहीं चल रहा. यहाँ हमें कख नजर नहीं आता. हाँ? इसके आगे हाथ नहीं आ रहा. हेलो हेलो आ रहा है. Now we are discussing the causes of hyperphosphatemia. Causes are decreased kidney function, low parathyroid hormone, developmental or autoimmune hypoparathyroidism, neck surgery or radiation, activating mutation of calcium sensors, defect, decreased parathyroid hormone, parathyroid hormone independent increased calcium, parathyroid hormone independent increased calcium, vitamin D and vitamin A intoxication, sarcoidosis, other granulomatous diseases, immobilization and osteolytic metastasis, milk alkali syndrome, severe decreased magnesium or increased magnesium, pseudohypoparathyroidism, acromegaly, tumor calcinosis, and heparin. These impaired renal phosphate excretion, massive extracellular phosphate levels, rapid administration of phosphate IV, oral or rectal, such as in cases of preparation for colonoscopy, extensive cellular injury such as crash injury, rhabdomyolysis, hyperthermia, fulminant hepatitis, cytotoxic therapy, severe hemolytic anemia, transcellular phosphate shift, metabolic acidosis, respiratory acidosis. Diagnosis of hyperphosphatemia is blood phosphate level is greater than 1.46 millimole or 4.5 milligram per deciliter, or greater than 1.6 millimole or 5 milligram per deciliter. Treatment is dietary restriction of phosphate binders, aluminum hydroxide, calcium carbonate, lanthanum carbonate, and sevelamer, and that is next is hemodialysis. So we have discussed once again the causes of hyperphosphatemia. Let's go once again on the topic of hyperphosphatemia. Hyperphosphatemia is increased level of phosphate in blood. Causes of hyperphosphatemia are renal failure, pseudohypoparathyroidism, hypoparathyroidism, diabetic ketoacidosis, tumor lysis syndrome, and rhabdomyolysis. Diagnosis is based on blood phosphate levels greater than 1.46 millimole or 4.5 milligram per deciliter. Level greater than 4.5 millimole or 14 milligram deciliter is severe. The management is eating low phosphate diet, antacids, calcium carbonate that binds phosphate, IV normal saline, and dialysis. Symptom and signs: non-calcium deposit, muscle spasm, and secondary hyperparathyroidism and renal osteodystrophy. Now, the causes once again for the acute, for the renal failure, causes of the chronic, causes of the hyperphosphatemia are decreased kidney function, Low parathyroid hormone. Developmental causes of hypoparathyroid hormone are autoimmune, neck surgery or radiation, activating mutation of calcium sensor, decreased parathyroid hormone, PTH independent increased calcium, vitamin D and vitamin A intoxication, sarcoidosis and other granulomatous diseases, immobilization or osteolytic metastasis, milk alkali syndrome, severe decreased magnesium or increased magnesium can also cause hypophosphatemia, pseudohypoparathyroidism, acromegaly, tumor lysis, tumoral calcinosis, and heparin therapy. Massive extracellular phosphate, rapid administration of phosphate IV, oral or rectal, exogenous intake, extensive cellular injury, crush syndrome, rhabdomyolysis, hyperthermia, fulminant hepatitis, cytotoxic therapy, severe hemolytic anemia, transcellular phosphate shift in cases of metabolic acidosis and respiratory acidosis. Diagnosis of blood phosphate level is greater than 1.46 millimole or 4.5 milligram per deciliter, or the management involves dietary restriction of phosphate binders, aluminium hydroxide, calcium carbonate, lanthanum carbonate, and sevelamer and hemodialysis. Now, this was all about hyperparathyroidism. We have now 10 minutes to go. We can discuss 15 minutes. Now we once again go to the hypophosphatemia. Hypophosphatemia. Phosphate is generally considered to be normal phosphate is generally considered to be 0.8 to 1.5 millimole. Children aged less than 1 year have normal level 1.3 to 2.6 millimole. 1 to 16 years age, the level of phosphate is 0.9 to 1.8 millimole. Significant hypophosphatemia, that is below 0.4 millimole per liter, may occur due to redistribution into the cells or renal losses or decreased intake. These are the three major causes of hypophosphatemia: redistribution into the cells, renal losses, and decreased intake. A normal diet contains plenty of phosphate as it is present in all living organisms. Normally, dietary intake varies according to the age and other physiological factors such as pregnancy. Recommended daily intake for children age 1 year is 460 milligram, age greater than 50 years is 700 milligram. Phosphate is absorbed in the intestinal tract. Normally, the majority of this is reabsorbed by renal tubular cells. Vitamin D increases uptake and homeostasis in terms of bone content of the phosphate. And renal excretion is controlled by vitamin D, parathyroid hormone, and fibroblast growth factor FGF23. These are the factors which control the renal absorption of the phosphate. Etiology: poor intake may be due to poor diet, including eating disorders such as anorexia, difficulty with chewing and swallowing, and alcohol dependence, malnutrition due to malabsorption. Secondary, severely ill patients is the most at risk when they start to recover and move from a catabolic state to anabolic state. Vitamin D deficiency, gut phosphate binders, for example, aluminium hydroxide, These causes the decreased intake, decreased absorption of the phosphate from the gut. Increased renal excretion, hyperparathyroidism, parathormone reduces reabsorption by the proximal renal tubules, high salt load, reduced sodium and phosphate, vitamin D deficiency, including hypophosphatemic rickets, renal tubular disorder, Fanconi syndrome, renal transplantation, drugs causing renal phosphate leak, aminoglycoside, cisplatin, and tenofovir, heavy metal poisoning, and paraproteinemias impairing renal tubular function. Osteogenic osteomalacia is a neoplastic syndrome of osteomalacia, hypophosphatemic renal phosphate loss, bone pain, and muscle weakness. It is caused by excessive synthesis and secretion of fibroblast growth factor 23, a phosphaturic hormone that is normally produced by the osteocytes. Several tumors can cause this, but most are benign tumors and mesenchymal in origin. Move from the extracellular to the intracellular compartment. The treatment of diabetic ketoacidosis, refeeding syndrome, acute respiratory alkalosis, the hungry bone syndrome, which occurs after parathyroidectomy, leukemias and lymphoma. Epidemiology common in hospitalized patients, 2.2 to 3.1%. Hospital intensive care unit can have 45% of patients with hypophosphatemia, sepsis 65 to 80%, chronic alcohol dependency 30 to 40%, major trauma 56 to 75%, COPD 20%. Hypophosphatemia is more likely in alcohol dependency, diabetic ketoacidosis, burns, and sepsis. X-linked hypophosphatemic rickets, 1 in 20,000 live births. In adolescents, it is often due to eating disorders associated with alcohol dependency, malignancy, and vitamin D level. Clinical features: chronic mild hypophosphatemia may be asymptomatic. Phosphate level is 0.6 to 0.8. Fatigue, muscle weakness, diaphragmatic and cardiac and skeletal muscles, bone pain and rhabdomyolysis, and altered mental state, confusion, hallucination. Severe acute hypophosphatemia less than 0.3 millimole may present with disorientation, seizure, focal neurological deficits, congestive heart failure, and muscle pain. Syndrome of chronic phosphate loss usually presents with bone pain, muscular weakness, skeletal disorders, markedly low phosphate with bone pain and excessive phosphate loss in urine suggests oncogenic osteomalacia. The examination, no physical signs. Hypophosphatemia starts in childhood, shows short stature in the adolescents, and bored legs from rickets. Adults, firm palpation of bones may show tenderness, hepatomegaly due to chronic alcoholism and underlying malignancy. Investigations: calcium, phosphate, magnesium, plasma protein in the presence of low phosphate. Increased calcium suggests or low phosphate suggests hyperparathyroidism. Low calcium and phosphate suggests the vitamin D deficiency, malabsorption, and hungry bone syndrome. Decreased magnesium suggests dietary deficiency. Consider paraproteinemia if globulin is high. Renal functions and electrolytes should be carried out. Renal tubular diseases and causes of electrolyte disturbance should be managed. LFTs, increased alkaline phosphatase and decreased phosphate due to osteomalacia. Parathyroid hormone levels and vitamin D levels. AVBG if respiratory alkalosis. Fasting morning urine phosphate content along with blood sample. Fanconi syndrome is renal tubular acidosis with low bicarbonate, low urates, low urinary glucose, and amino acid urea. X-linked hypophosphatemia, genetic testing. X-rays can help to uh, evaluate osteopenia and osteomalacia. Hyperparathyroidism. Loser zones suggest osteomalacia, erosion of the distal phalanges and clavicles, and circular punched out lesions. Bone scintigraphy demonstrate increased uptake of multiple areas of severe osteomalacia. Ultrasound of the neck. Ultrasound of the neck may help to identify the enlarged parathyroid and thyroid gland, but technetium 99M scanning can be more accurate. DEXA scan can be used for bone density, loss of bone density. Bone biopsy will also show loss of bone density. Management includes mild decreased phosphate, no treatment. Severe decreased phosphate may require artificial ventilation and intravenous phosphate. Treatment is dependent on the cause and severity and duration. Treat the underlying cause. Phosphate supplements and oral or parenteral. It can result in severe hypocalcemia, increased phosphate, and increased potassium. And patient with poor renal function is at high risk. In celiac disease, we give, and Crohn's disease, patient should be given vitamin D. Should be given vitamin D. Oral phosphate supplements can be beneficial in genetic disorders, remove mesenchymal tumors. Vitamin D deficiency is the treatment with oral vitamin D, or with in renal diseases is 125 vitamin D3. Parathyroidectomy in cases of hyperparathyroidism, avoid alcohol, decrease eating disorder to reduce the risk of hyperphosphatemia. Patient having renal transplant may be considered for parathyroidectomy, and calcimimetic agent sinacalcet. Complications of acute hypophosphatemia can produce seizures, delirium, coma, and focal neurological findings. There may be heart failure, rhabdomyolysis, acute hemolysis, leukocyte dysfunction, and abnormal LFTs. Complications of acute hypophosphatemia can produce seizure, delirium, coma, and focal neurological findings. There may be heart failure, rhabdomyolysis, acute hemolysis, leukocyte dysfunction, and abnormal LFTs. Heart failure and rhabdomyolysis, hemolysis can cause acute kidney injury. Platelet dysfunction, glucose intolerance, and metabolic acidosis. Chronic hypophosphatemia. Chronic hypophosphatemia due to phosphate loss causes bone pathology, rickets, short stature, and bony deformities in children. Adults may develop osteomalacia with severe bone pains and fractures. Prognosis correction of acute hypophosphatemia tends to leave no long-term complication. Failure to recognize and treat an acute severe situation can lead to fatality. X-linked hypophosphatemia, rickets, and vitamin D resistant rickets are only incompletely treatable and result in lifelong skeletal deformities. 2 to 4-fold increase in mortality in hospitalized patient. 2 to 4-fold increase in mortality in hospitalized patients with severe phosphate deficiency. Prevention: high-risk patients such as renal dialysis, transplant, eating disorders, parathyroidectomy, oral and parenteral supplements should be given. Thank you very much. If you have any question,